ただいまよりパネルディスカッション近未来の医療を支えるプライマリケアを開始いたします。座長は日本プライマリケア連合学会理事長丸山泉先生、そしてインディアナ大学教授トーマス・乾先生です。それでは丸山先生、乾先生、お願いいたします。
はい、皆様、こんにちは。今日はですね、私、日本プライマリケア連合学会の理事長の丸山でございますが、非常に高名なトーマス・乾先生をお迎えして、私と一緒に座長をやらせていただきます。トーマス先生にはまとめの方を主体的にやっていただきますけど、まず今日のご参加の皆様方を簡単にご紹介いたします。で、まず右側は皆さんご存知の乾先生でございます。それから乾先生、インディアナ・ユニバーシティの教授でございます。もうご高名ですので皆さんよくご存知だと思います。それからアマンダ・ハウ先生はイーストアングリアですね、UK のウォンカの次のなんて理事長会長なんていうトップですね。でplease。はい、続きましてシンガポールのデューク大学のジェネラルホスピタルの准教授のリー・ケンコ先生です。続きまして、ジョン・ホプキンズのプライマリーケアポリシーセンターのヘッドでございますが、リュウ・シー先生、よろしく。それから私どもの学会の副理事長をしております草場鉄舟でございます。ではオープニングにあたりまして、私からこのパネルディスカッションの趣旨説明をさせていただきます。皆さんご存知のように2017年の、後期研修といいますか専門医研修に入る、若い医師、つまりその人たちは2020年に誕生するんですが、そこに初めて日本で19番目の新しい領域として総合診療専門医というのができることが決まっております。でいよいよですね、コンピテンシーもプログラム、カリキュラムもほぼ決まった状態になったわけでございますが、そういう状態ですけれども、私たちのプライマリーケア、日本におけるプライマリーケアというのは実は非常に確固としてございます。つまり、日本医師会っていうのがありまして、かかりつけ医という名前で呼ぶんですけれども、日本各地北から南まででしっかり診療してくださっている先生方がいらっしゃるわけです。しかしそこに、私どもの日本においてはやっぱり領域としての確立、がなかったと。そういうことで19番目にプライマリーケアのために大変重要であるという総合診療専門医を作るということは、ある意味領域の確立、新しいジャンルの確立になるわけです。でそれをもう数年先に起こるわけでございますけれども、もう準備に入っておりますが、そのことを前提にいたしまして、今日はイギリス、そしてシンガポール、アメリカ、そして日本の実情をですね、皆さんから出していただいて、我々が専門性という意味では新しく芽が出たばっかしでございますので、これをどう進めていくかということをですね、少しディスカッションしていただきたいと思います。では、これからは乾先生にお願いしたいと思うんですが、よろしいでしょうか。
Konnichiwa. I'm happy to see so many people interested in primary care. My responsibility will be to lead us through the sequence of speakers. I'm going to explain first that they have quite reasonably preferred to sit on the floor so that they can see one another's presentations, just as you will see them, and they will join us here in the front for the questions and responses that we'll finish up with. we hope to preserve about 20 minutes for Q&A. So I believe Professor Howe is going to lead off. She says that she is going to offer us a framework for understanding primary care with particular reference to the aging society. Professor Howe.
Thank you. Good afternoon, colleagues. It's an absolute pleasure and a privilege to be here. And I hope that the contribution I am going to make will be useful for you. I'm sure I'm going to learn a lot, and together we can make things better for our patients. So I'm from the UK, as my colleague said, and thank you very much for the kind welcome. The title that we have for our plenary you see here, but some of you who know English very well will know that the word super has a very positive meaning. So if I say to somebody, they say, would you like to come to Kyoto to help with a policy summit? I say, that would be super. So really, my question today is, how can we keep old age super? Because often the image for us around older people as they become sick and frail is that it's quite frightening. And for younger doctors and nurses certainly to be in contact with people at the end of their life, unless we do this very well, can be a disabling experience. And so I think it's very important today that we think about how we can make this as positive as it can be. So everybody knows, as the excellent talks in the opening plenary showed us, some of the issues. Falling mortality, we have more opportunity, both socially and medically, to prevent ill health. People are having fewer children per family by choice, so that those children, less mortality, as we saw, living well, living longer. And we have more treatments, even in later life, to prevent ill health from non-communicable diseases, which is giving us, thank goodness, more years of healthy life. So I think that is something to celebrate. But on the other side, the problems we are discussing, more older people whose cost of care, both in their time and their efforts and those of their family, but also for the health professionals and for governments, brings more costs later in life, and fewer people actually available day to day. I'm a working woman, and I know how difficult it is to look after dependents while you're also doing your own work. And so we have a greater need as society throughout the world to find new ways to maintain quality of life and function in spite of natural aging. I want to, of course, speak about primary care, and one of the big discussions globally is about how to strengthen our health systems. And one of the main routes that is being recommended is using primary care more effectively. So this is a statement from Barbara Starfield's work, and I will let you read it. The achievement of equity in health services and health is an imperative everywhere, and primary care is inherently a more equitable level of care than other levels of care. Potentially, I would say, less costly, sparing resources that can be used better to other disadvantaged communities, and it narrows disparities in health between the more and less socially deprived. So this is the evidence-based, but also aspirational statement about what good primary care can do in a health system. And Margaret Chan said, in the absence of primary care, patients tend to flood hospitals. And this is partly why costs go up, not just because of aging and need, but because of the way the service is configured. Without primary care, it is costly. And I am a family doctor, and my organization advocates for the role of doctors in the community, part of the primary care team who can help with this. So I just want to say, why does that matter? Because doctors who are properly trained as generalists in community settings, general medical practitioners, family doctors, can manage many problems. And of course, as we get older, we tend to have more than one medical problem. And this helps the cost effectiveness of the primary care team. In the absence of a family physician in overall charge of care, treatment by several hospital specialists can lead to duplication of investigations and procedures and risks of drug interactions to which the old are prone. This is again Margaret Chan, and she also said the world needs more family physicians. So that's the advert over, but I am going to give some definitions. Just to be clear, WONCA, it's a funny name, but we're the World Organization of Family Doctors. We have a large membership, 140 different countries around the world. And many people don't yet know what a family doctor is. It's automatic in my country. We call it general practitioner, but it is a specialty with a proper postgraduate training and quite a difficult exam. And we are community-based generalists who are trained to deal with people across all their life stages. And that means that we can deal with all types of health problem at the first point of contact. So when any patient comes through the clinic and needs medical advice, we can do that job. And we offer in good primary care, with family medicine embedded within it, the service will be comprehensive, accessible, focusing on a community, not just the individual who comes once, but looking after a group of people in a community over time, which allows continuity and centered on the care of people, not specific parts of the body or diseases. So that's the definition. Probably many of you would know that, but just to remind ourselves. So going back to our theme for today, for this afternoon, colleagues, I want to look at this, at what does this mean? How can we make primary care effective in this super aging society at the level of the individual professional, the clinic team, that community they're working in, the health system, the whole of society, actually. It's not just a health systems problem, and the role of the patient. So a few slides on that. From the professional point of view, this seems a very simple thing to say, but actually we have to do fundamental principles to get this right. First of all, we must train our health professionals to respect older patients. I don't think that's such a big problem in Japan, but I'm sad to say in my country, we have seen some really bad things happen in the care of older people, partly because I don't think we train our young doctors and nurses always well enough. So one of the values of bringing people out of the hospital into the community is there they can learn medicine from the elders who are there, who are often not so sick as when they're in hospital, have some chance to talk with the young doctors, to explain to them what it means to have had a stroke and still be living with diabetes and hypertension and the after effects of the stroke, and how I still want to go take my grandchildren to school in the afternoon, doctor. And these are the kinds of things that actually give younger people another positive view of older people's resourcefulness and their resilience. It reduces stereotyping. So again, you don't just see this person as old and sick. You start to remember that they're a real person with a life and some resources of their own. And it's also a very good place to learn about medical comorbidities. Okay, so when I have students and residents in my clinic, they have a lot of time with a lot of patients, with a lot of the different problems of later life, but the patients are not so sick, and they can learn to manage the different issues in one clinical setting with that patient. So it's a good place to train, and it teaches us also that good attitude to older people, positive attitude. It also helps the doctors, nurses, whatever they're training to do in the health service, to differentiate between non-communicable diseases and the illnesses of aging and frailty. Again, one of the slides this morning made this point, but diabetes, hypertension, it's not the same thing as risk of falling, risk of fracture, cataracts, dementia. These are the particular vulnerabilities of older life. And doctors in the community and nurses in those settings need to understand all of them and have some ability to help to diagnose and manage both. So the team then. We need, I think, to think about how our teams help older people. Now again, the mantra, the criteria of good care is it's accessible, it's available, it's affordable, it's acceptable, and it integrates the care around the person, not their diseases. So what that means with older people, and we're trying to do this in the UK, and I think in many countries in the world, is you need a different skill mix. Just the individual doctor on their own probably won't be enough for the Super Aging Society's good primary care team. There will be role for nurses, for healthcare assistants. This is a group who are, in a sense, from less complex training backgrounds, but still can be very effective as part of the team to do some of the clinical work with these patients. And older people will also need interventions in social and community care support, including opportunity for home assessment and indeed home nursing care for periods in their life. And those teams, the good primary care team and community team, will have to interface, of course, with the hospital, but also with other types of centres. So the ideal team, health service for older people, also includes good rehabilitation and what I call low dependency unit. That doesn't mean the big acute hospital, but the sort of hospital where you can bring somebody after an operation for a few more days to get them properly back on their feet before they actually go back to their apartment on their own, that kind of thing. Or if they're a little bit ill, you can do the diagnostics there with some nursing cover, with a drip up, community hospital kind of beds, low dependency unit. Without that, the patient has to go straight into the big hospital, probably will get ill because they're in the big hospital. So this is a very important part of the new team. Community clinic, then, I said we also need to think about what exists in the community to help those older people in a more informal way. So I don't know about you, but in my town we have a lot of charitable bodies, informal networks, neighbours who are really important to helping my older patients. I can come to the home, do the work, give the prescription, but maybe my older patient relies on her neighbour to go to the pharmacy to get her prescription, and that's very helpful to me. We need to be sure that that is supported. We need to give specific support for family and carers. Being a full-time carer is a very hard job. And in our country, we've looked quite a lot at the evidence that people who do full-time care for somebody who's very dependent tend to get sick themselves, get exhausted, get depressed. So in our systems, we need to think about how we offer support, formal and informal support to those people. And I just give you a few examples from my own place. Ways of getting good meals to a patient who isn't able to shop or cook for themselves at the moment. A place that an older person might like to go to get some social company and support in the day so that they're not lonely. Using the new technologies to be in touch with them so they don't have to come to my clinic to get their results. Even a phone, I can phone my patient to save them making that big journey to me. Home-based care, good housing. I think we have a session later this afternoon about physical infrastructure design, which really makes a lot of difference, and transport, of course. So we need to think about this when we're health workers to advocate for these other parts of the system to work as well. And my message is nobody should be neglected. The system should not let people fall through the cracks. At a bigger level, the health system drivers, of course, what will help us to do this? Incentives have to reward the health service for looking after older people well, and that means giving you time to do the job, giving you the resources into the workshop, or if you're in a fee-for-service health system model, giving you proper recompense for doing that work, giving you the right training, and actually encouraging you to work with these other systems. One problem in my place is if I go off for an afternoon to the local prefecture to talk about older people's services, who is going to run my clinic? So, you know, those kind of things take time and resourcing as well. But the aim, and in Wonka terms, we are really committed to the universal health coverage and designing care packages that do not deter older people for coming for the help they need. So no financial barriers at that point of greater need, because otherwise people don't come, they won't use the medications, they won't come for the checkups, they won't take the vaccine, and they won't come for their reviews. And all that has to be quality assured at the level of the provider so that the public, the government, are sure that the patients are getting the care they need. And those are the sorts of systems drivers that we need to put in to make the whole system work. Societal drivers, I go through this quite quickly, I may be a little late. This, of course, depends on what value we put on our elders, what we think the payback is for the contribution they make to us, the resources they still offer us. I think it is a test of a civilized society, how we look after older people. And that's a moral imperative. This is a personal view, but this is what I think it really is about. And it's also about what we want for ourselves in our old age. So if you want good care, make sure that we get it in place so that it's ready for you when you get there. There are big questions, and this is not the purpose of today, but about over-medicalisation and doing too much for people later in life. The surgical colleague this morning said, you know, at what point do we stop? And that's a big discussion too. But still, I think good care is about making the right offer to the right person for their needs in that setting at that time. And the role of the patient, of course, is to be part of our team too. And that means they look after themselves where they can. They need to take on understanding what their conditions are and what is needed to look after themselves. They need to take the stuff that we give them and go for the tests that we recommend. And all that's part about me explaining properly and them having the opportunity to do it, sharing the decision, sharing their preferences, sharing their priorities. And that means then whatever the fullness of their life can be, they will be able to live it. They won't have to spend all their time going to the hospital to see different specialists, and they can spend most of their day, hopefully, not being patients and having some control over their lives. So I have some examples. I think you will have to think about your older patients and fill those examples in because I've talked too much already. But in conclusion, this is my punchline. Primary care for a really super aging society should have care of the elderly as part of its core function, be resourced to give great health care in the local community in a way that is cost-effective and comprehensive, which we already know a lot about how to do that. Not just doctors, but nurses, other health workers, other community and hospital resources, and the aim to avoid being in a big acute hospital, if possible, or for as short a time as is needed. It's not about refusing choice. It's not about saying you can't go to the specialist. It's about saying you don't need to go to the hospital because we've done all this stuff here already in your place with you. And that together should enable patients and their families to live as well as they can for as long as possible. Thank you very much.
Thank you. We're going to hold questions until all of the presentations have concluded. So I would invite Professor Yu, or Shi, next to the podium. He informed us before the presentations that he was going to have something to say about measurement and evidence. I should warn you, I should have said this before. Since we said we were going to go 15 minutes, at 15 minutes, I'm going to take this and turn it like that so that you know that you've come to the end of 15 minutes. And if we get to 20, I'll have Dr. Maruyama do the same. Yeah.
Okay, so
thank you so much.
All right, so well, thank you very much, everyone. Good afternoon. It's great to see everyone interested in primary care, and our session turns out to be larger than this morning's. So today, I'm going to talk about primary care Specifically, I want to cover three things: how to measure primary care or conceptualizing primary care. And secondly, I want to provide some evidence of the efficacy of primary care. And finally, I want to talk about how to improve on primary care system from a healthcare system perspective. So, in terms of the measuring and conceptualizing primary care, let's start it with WHO's definition. This was WHO's International Conference on Primary Healthcare held in 1978. As you can see, the underlying part really formalized the key concerns of primary care: universally accessible, affordable, and first contact care. To summarize, my colleague, now who passed away, Barbara Starfield, had summarized 4 key attributes of primary care. Those are the attributes that are only amenable to primary care, and none of the other physician providers share those. None of the other specialties share those. Those are first contact, which means patients get into the health system through primary care. Longitudinality or continuity of care, meaning the ongoing relationship that you can only have with your primary care doctors. And then comprehensiveness of services. And finally, coordination, integration of care. So to measure primary care, we want to look at those 4 key attributes of primary care. The Johns Hopkins Primary Care Policy Center that Barbara and I founded in 1997 with grant from the US government developed a series of primary care measurement tools that measure primary care at the provider, patient, system, and facility levels. Those tools are widely used worldwide in over 30 countries, and many publications have been using those tools, and those are freely available, made available to researchers, evaluators, and health systems. So the other term that's often get confused with primary care is called primary health care. Well, primary health care is primary care at the population level. Perhaps this diagram, this figure, illustrates what primary health care and primary care is. As you can see, we individuals go through life under a variety of hazards in the environment. The objective of primary care is to prevent us with preventive knowledge and treat us diseases as we have it. So the focus is on clinical aspects at the individual level. However, primary health care is at the population level, and its focus is on removing or reducing the hazards in the environment that happen to impinge on our lives. So you can see both primary care and primary health care are important. By tackling both individual and population level, we are actually addressing the determinants of health. Now I want to look at the efficacy of primary care, looking at the many studies, researches we have done over the last 15 to 20 years. This is a slide that shows US primary care physician by population by state. As you can see, states with higher primary care physician to population ratio also show higher life expectancy. We use that for specialist population ratio, it doesn't work. We use the same method for total physician and population ratio, it doesn't work. Only primary care physician population ratio works. So you can see there is a positive relationship between primary care physician in your state and how long you can live. This is a study we do with OECD industrialized countries data. We look at primary care strength measured by our tools. Those are called primary care scores. And we look at per capita healthcare expenditure. As you can see, there is a significant inverse relationship between how much we invest in primary care and how much we save on healthcare expenditure. People will say, look, US is the outlier right there on the right lower hand side. Well, removing the US from the equation, you see the same inverse significant relationship. So primary care not only saves lives, but also reduces costs. We look at over 30 years of data from industrialized countries, dividing countries into higher primary care emphasized nations and lower primary care emphasized nations using our primary care assessment tool at the system level. As you can see, we compare primary care and its impact at premature mortality. The lower primary care countries show a higher mortality rates consistently over those 30 years than higher primary care emphasized nations. So you can see primary care does extend life. There are many studies we do. Just cite a few more examples. This is a study using US counties as the unit of analysis. Counties also have higher primary care physician and population ratio versus lower primary care physician population ratio. Counties with higher primary care population ratio have lower overall mortality. Look at the total mortality, 953 per 100,000 population versus 1,030 per 100,000 population. And this is true also for heart disease mortality, cancer mortality, all the leading causes of death. We also look at how primary care addresses disparities. Two of the disparities that affect world population are income and race ethnicity. Gini coefficient is a common measure of income disparity. As you can see in this model, using US data over 1985 to 1995, 11 years of data at the state level, we can see primary care actually reduces the impact of income inequality on mortality, using not only same-year analysis, but 1 year, 3 year, and 5 year lagged analysis. So those series of models actually, by introducing primary care, income inefficient, represented by the Gini coefficient, was reduced. First, in model 1, it was significant, but by adding primary care, it was no longer significant in model 2. However, primary care remains significant even after you introduce socioeconomic determinants of health. And this is true for racial mortality. We look at white and black mortality. As you can see, primary care has a greater impact on black mortality than on white mortality. So you can see primary care not only extends overall life, but also addresses or mediates racial and income inequality on health. So finally, I want to talk about how to improve on primary care performance. Since I'm a professor of health systems and health policy, I want to talk about it from a health system perspective. There are 4 pillars that comprises a healthy healthcare system. They are financing, organizing, delivery, and operating. Under each of those components, there are critical elements. For example, under financing, a good healthcare system should have universal coverage, lower out-of-pocket spending, especially for primary care services, and there should be cost containment built in the system. And then in terms of organizing, there should be a clear referral system, either through primary, secondary, or primary directly to tertiary. And there should also be geographical and specialty balance of distribution of resources. And finally, any good system should have a safety guard or safety net provider for vulnerable populations. And then the third component, delivery of care. A good system should have continuum of delivery, integrated care, and emphasis on clinical quality. In terms of operating, the emphasis should be on management, efficiency, and satisfaction by both providers and patients. So let's look at how primary care can improve on those aspects. I'm going to focus on organizing and delivery. So from an organizing perspective, there should be a well-defined, clear referral system or tiered system with insurance mandates. So strengthening primary care should start by strengthening gatekeeping, particularly in rural inner city areas where lots of the poor underserved populations stay. And then there should be improved quality of health services, again, particularly at the lowest level. Many countries, especially developing countries, people do not voluntarily use lower level care because of the perceived or real lack of quality. And then there should also be geographical and specialty distribution of resources. So we should expand primary care workforce that not only include clinicians, but also ancillary alternative providers, such as nurse practitioners, physician assistants, even social workers, and so on. And we should also emphasize the healthcare team effect. And finally, safety net provider. There ought to be real public hospitals and clinics that care for vulnerable populations. And the private market should also have a place in any good, well-established system to cater to the needs of those more well-off and also to create competition for the public sector. So in terms of delivery of primary care, the emphasis should be on continuum of care, integration of care, and clinical quality. So there should be a paradigm shift from how we think, from current emphasis on illness to an emphasis on wellness, from emphasis on acute care at the hospital setting, especially in Asia culture, to emphasis on primary care, which is typically at the community or outpatient setting. From an emphasis on individual health to an emphasis on community well-being, and from a fragmented care to an integrated managed care, and from a service duplication mentality to a continuum of services. Information systems should be the key to hold all the system together. A well-designed integrated system should have information system at its core that allows providers in the community to share information about their patients, the services they receive, so that patients, wherever they go to, don't have to repeat those information, and they can receive non-duplicative prescriptions and treatment from providers. And providers will be there to guide them to the best way of care. So finally, I want to share with you, those are the resources, bibliography that we have produced over the last 20 years that summarize the efficacy of primary care. Okay, thank you very much.
Thank you, Professor. So a picture is beginning to emerge in which we believe that rather comprehensive support for health through healthcare and health development that might focus on the individual and community might not only be affordable, but might, under certain circumstances, save money, save lives, and improve the quality of life for the individuals we seek to serve. Now, within the region, there is innovation moving in the direction of strengthening these kinds of primary care services. We're going to hear from Lee Hock, professor or associate professor at Singapore General Hospital, about some of the directions of innovation and reorganization taking place in Singapore.
Thank you. Thank you, Professor Maruyama and Professor Inouye. Good afternoon, ladies and gentlemen. I have a big problem on my hands. I have more than 20 slides and a 5-minute video, and I understand I only have 15 minutes, so apologies to the translators. And I hope your name card don't flip a few rounds before I finish. So I'll go right in, and I'll speak rather fast, and I'll skip through certain slides. There's a sort of a repetition. So we are here because of super aging, and it's not just in Japan, it's around the world. This is the aging around the world. Japan leads the world. But they are not alone. Everyone is in the same trend. Singapore is quite near. This is where we are now. This is where we are 2030, 2050. The whole world is aging, and Asia is leading the pack in all the continents. So bad news for everyone. But more importantly is that it's not only we are having more older people, we are running out of younger people who are economically active between the age group of 20 to 64, who should be working in the banks and in the army defending the country and churning out resources to support the old, but they're all declining. Korea, Singapore, Japan again, and we are declining very fast. In the Western countries, they are declining, but they are it's not so drastic. So in our part of the world, within generations, you can feel the effect. And this is Dr. Margaret Chan, Director General of World Health Organization. He gave this speech at our World Conference recently, And she said that the things have changed completely. And as our co-chair this morning told us, we need, Professor Fukuhara told us, we need a new medicine for the new era. And in new medicine, I think he doesn't mean, and we all know he doesn't mean there's some new drugs that we invent, but we need a new model of delivering care, especially primary care. So WHO also tells us resources are finite. They're running out because of the increased utilization. There's a lot of wastage. As much as 40% of all the money we spend on healthcare is just evaporated, it's just wasted. Every dollar we spend, 40 cents just get thrown away, and we are effectively only using 60 cents. So we really need to be very frugal. We need to think of more effective and efficient way to solve this problem. And no country, no matter how rich, will not be able to afford the healthcare system of the future if we continue with the present state. And this is an article by a very renowned medical writer, Atul Gawande, and he alerted the world to this new phenomenon of a group of people who he referred to as the super utilizers. They just consume disproportionate amount of healthcare resources. So in this part in Camden, he said that 1% of the population is responsible for up to 30% of the utilization of healthcare resources. So if we want to solve the problem, then very naturally we should attend to this group of people. So in Singapore, we are more pragmatic. We are famous for our Singapore Airlines, so we call them frequent flyers. And these are the people who come to our hospitals repeatedly. We are glad that they come, but it means that we are not doing a good job if they keep coming back. So we have programs that we say we must solve the problem of these frequent flyers, and these are the high utilizers of services. And the older population have a greater need of resources that translate to per capita healthcare cost increase. So you can see the line just go crazy after age 55. You know, it just go up and up, right? Regardless of which country you are. Some are worse and some that, yes. So Singapore's challenge, we are the same. This is our population above 65. It keeps going up from 2000, 2015. And by 2030, we're expecting 24% of the population. And as I said, we are running out of young people. 2015, we have 4.8 to 5 working economically active people supporting one person above 65 who should be happily retired. By 2030, it's down to 2 to 1. And no matter how rich we are, we can't afford. It's like cutting down half the working population of the country and still having the same, if not a higher expenditure for healthcare. And more worrying is that I think many of these elderly are living alone. This is the numbers that are living alone. Elderly living alone means they don't have the support and resources. They are socially isolated and they are at high risk of ill health. And this is people who are living alone, elderly, and they are functionally disabled, as we again heard in the opening lecture. And this is a major problem. And that is this end result. Recently, we have this thing hitting the Singapore headlines, hospital facing severe bed crunch. We run out of hospital beds. We have to put patients in the corridors. And this is the innovation in one of these hospitals to cope with this crisis. So many of us are thinking that, okay, the present primary care is not enough, right? We need a new model. And for want of a better word, my co-workers and I think we need the intensive primary care, just like you need intensive care unit for patients with very, very complex medical problems. We need people who need just a higher level of primary care that our present primary care is unable to deliver, right? So back in 2006 in Singapore General Hospital, this is our largest tertiary hospital in Singapore, and where the care is at its most fragmented and silo and lots of problem of integration. So they say, let's have a group of doctors who can do this integration bit. And they look around and say, who are the best people who can do the job? Who is trained in good general medicine? Who is very community-oriented? Who are very sensitive about the need to use resources appropriately? And they said, family medicine. So they invited a group of us to form a department in the hospital, charged with this mission to say, can you help us solve this problem? We need a solution. Also, we started a model. So we created this new model of care, which we sort of borrowed with permission from the United States. It's called a hospitalist. But we believe that you need to do more than just being a hospitalist, which means that you just focus on the care in the hospital. We say you need to do in the hospital and then bringing them back to the community. Your job is not done when the patient leaves the hospital. So we have this adapted hospitalist program that sort of incorporates some of the family medicine principles. But we are very worried because this is a new service. What if we are killing our patients for this new model? So we said, let's be very careful. Let's do a pilot. Let's see how we compare. So we have usual care, and we have a group of patients who get admitted to our service, which we refer to ourselves as the family medicine hospitalists. And you can see that the comorbidities are the same. So we're not gaming the system. Diabetes, all the nasty comorbidities that's very prevalent that creates complex needs, they're all about the same. There's no statistical significance in the two groups. And we find that unscheduled readmission is about the same. Hospital mortality, thank goodness, we are just as good. But the very interesting thing is that the length of stay is decreased by up to 1.5 days, which is 1.1 day, which is quite remarkable because the average length of stay in Singapore in acute hospital is about 5.8 days. And that translates to savings because every day in a hospital costs lots of money. Now after that project, we move on to phase 2, which we develop a slew of services aimed at further improving care continuity. We call this an integrated clinical care service. Essentially, is an extension of what we did originally. The inpatient team, comprising family doctors and our multidisciplinary team, will take over the care of patients that we target and consider to be at high risk as the so-called high utilizers. Then after discharge, we do not leave them alone. We admit them after discharge into what we call a virtual ward, where our doctors and our team continue to keep an eye on them, as if they are still in our hospital. So we call them, and sometimes when they run into trouble, we send a transitional home care team out to the hospital. So we do not want them to come back to the emergency room, and the poor emergency room doctor seeing such a complex case will surely panic and admit the patient. So we said, before they decompensate, before they come to our hospital A&E, let's go out and fix the problem for them. So we had this transitional home care team. And we also have a post-acute community hospital, which is affiliated to our hospital, again, where family physicians work. So after discharge, 5.8 days in the acute hospital, different criteria, palliative, rehab, whatever needs you are, but you're not well enough to go home, come to this hospital. It's a very low-cost hospital. It costs only $300 a day, Singapore dollars a day for a general ward bed, compared to an acute hospital, which costs up to $1,000 a day. So this is tremendous cost savings, both for the system as well as for the patients. And we have encouraging results so far. Great reduction in length of stay, hospital admissions, ED attendances. But this is not a randomized controlled trial, so there's some significant limitations in the study. But generally, I think the trend is reassuring that there is probably some impact. The final stage we want to go through now, which is next year or so, hopefully this year, and we are in discussion, and the Ministry of Health in Singapore is agreeable to fund us, is to bring this whole concept down to the population. So before they come to a hospital, we put the team out into the community. And this is a community of elderlies at risk. So in Singapore, the country is very well off, but even in Singapore, there are elderly at risk who are socially deprived. They do not have the resources to support them. They're living alone at home, sometimes with significant disability. We say, let's bring the team to the community. So we are experimenting this third phase called the integrated community of care. Okay, so I think I would like to invite my colleagues to tell us, rather than me telling you everything, I put them into a video to tell you what we are actually doing. I think it will be more effective. So I think I should have enough time for this 5-minute video. Welcome to the Department of Family Medicine and Continuing Care. I'm Dr. Lee Keng Hock, the head of department. At FMCC, we provide comprehensive and continuing care to our patients from the hospital to the community and back to their home. This video will feature many of my doctors and the interesting things that they do and our commitment to patient-centered care in this hospital.
At SGH, we have opportunities to provide holistic inpatient and post-discharge care for our patients. There are also exciting opportunities for medical education and research. Our integrated clinical care service provides comprehensive inpatient care for our patients who are at high risk of readmission and have complex care needs. We'll review their medical conditions, execute good discharge planning, and integrate them back into the community. This is possible with our multidisciplinary team, our nurses, pharmacists, and social workers. Our nurses will educate patients in disease management, our pharmacists will assist with medication reconciliation, and our social worker will activate social resources for our patients. After our ward round, we'll gather as a team again to discuss about patients who are discharged back in the community. Through regular phone calls, our integrated care nurse will identify problems early, and our doctors will review this patient in our early review clinic and also in their home.
FMCC has been running a transitional home medical care program since 2002. We are unique in the sense that we provide a multidisciplinary care directly to our patients' homes once they're discharged from hospital. In the home setting, we stabilize our patients' subacute and chronic medical conditions, as well as empower them and their caregivers with the necessary skills and knowledge for self-care.
我从医院回家 ，Dr. Tan 护士来看我，来鼓励我。
Bright Vision Hospital is a 318-bedded hospital that provide continuing care and rehabilitation service for patients that requires further rehabilitation and improvement in their ADLs actually after discharge from the restructured hospitals. We try to improve the patients' ADLs and improve their confidence so that they can function as good as possible back in their own home.
FMCC also has a preventive medicine arm. At the Health Assessment Center, well patients are seen for screening for silent disease. Subsequently, they are offered disease education as well as coaching in lifestyle changes. When you are posted to the Health Assessment Center, you will be trained in skill sets to empower patients effectively for lifestyle change, which is the way to go to reduce disease burden and health costs in Singapore. So I'm personally very happy to see many patients who successfully lose weight or reduce cholesterol levels after my encounters with them. Our department has a strong academic medicine record. Most of us hold faculty positions in the Sing Health Family Medicine Residency Program in NUS and Yonglulin Medical Schools, and we also train family physicians under the College of Family Physicians. Like most of my colleagues, I spend a significant amount of time training residents and medical students attached to our department. More importantly, we have a structured training program to train our medical officers to be competent in complex care so that you can be versatile in any family medicine setting in Singapore.
Being an academic family medicine department, FMCC is actively involved in research to improve patient outcomes. We collaborate actively with researchers from the Singapore Clinical Research Institute as well as NUS University. In FMCC, you can look forward to the experienced mentorship when you take on research projects that will improve patient outcomes and shape the way healthcare is delivered in Singapore.
No, of course not. So I was actually lucky enough to work in family medicine. And during this time, I found that we're more like one big family. Even our seniors, they get to know us. They take a lot of time out and talk to you, find out what you like. Yeah, and I think this actually translates down to the junior staff, and we end up being very close. We go out for makan sessions, go out for movies, and we actually celebrate each other's birthdays together.
I came here to Singapore like 5 months ago. My initial apprehension proved to be wrong, and it was later changed to the warmth and collegiality of my colleagues here. They helped me to settle in quickly, and we soon became close friends.
I actually discovered that there's more to family medicine than what everyone thinks. You know, it's not just being in a GP clinic. I think as a young doctor, you don't really realize that. I started in SGH, and then you see patients there, and you send them either home or to Bright Vision for rehab. After they stay here for a couple of weeks and they go home, you know, I actually feel really confident that, oh, you're going to make it at home, you're going to be fine, you know. I think that was that was really fulfilling for me.
Family medicine.
Okay, thank you very much. I'll take questions later.
And so we begin to see that in the new initiatives there are transformations of systems, morphing of organizations. Earlier we heard there's an emerging discipline of primary care here in Japan, and so I invite us to hear from Dr. Kusaba, who can tell us a bit more about this workforce issue.
Yeah, okay. それでは私は北海道家庭医療センター、また日本プライマリケア連合会副理事長の草場でございます。ここからは日本のプライマリケアの現状ということを高齢社会の中でどう捉えるべきかお話をしてまいりたいと思います。日本語で話させていただきます。まず日本の現状についてのお話をした後、日本の政府自体もですね手をこまねいているわけではなく、さまざまな医療政策を打ち出しているこのことをお話しし、で最後に、先ほど丸山先生の方からもご紹介ありましたように総合診療医ということで、一つのジャンルをですね今確立しようとしている非常にチャレンジングな時期であるということを、説明していきたいと思います。またこのスライドの一部はですね大阪大学の中村康秀先生から、ご利用許可いただいて使わせていただきますので、一言申し添えておきます。では日本の現状です。先ほどから、スライドで、何人かの先生がお出ししていただいているように、現在日本の高齢化の現状、こういった数字で示されるということでございます。現在65歳以上の方が 23% ですが、それが2050年、60年には 40% になる。また人口は徐々に減少していくということと同時にですね、下の緑のラインを見ていただきたいと思います。で緑のラインはですね、これは20代から69歳、つまり成人として活躍されている方とですね、その70歳以上の方の比率を見てるんですけども、1950年の時には 18.3 人で1人を抱えていたものがですね、現在は4人で1人の高齢者を支え、そして数字の方はどんどん下がっていって、2060年の時点では1.4 人で1人、つまりもう1対1で高齢者を支える、そういったような状況が今生まれようとしているということでございます。高齢化そのものはですね、決して別に、高齢者のですね、本当に生活を支えるという意味では何ら悪いことではないんですけども、一番大きいのはこの社会の変化、これが一番大きいということでございます。そして日本におけるですね、高齢者の死亡の、原因について、ご覧いただくとお分かりだと思いますけれども、やはり悪性腫瘍が一番多いんですが、心疾患、また、セレブラバスキュラーディジーズということで、心血管疾患、などですね、肺炎、こういったたくさんの疾患を合併しながら、亡くなっていく、こういった高齢者がどんどん増えていく。つまりさまざまな疾患を同時に抱えながらですね、暮らしていくことが当たり前になっている今の日本の現状ということで、マルティモービリティという言葉でそれを一言で言い合わせるということでございます。また同時に高齢化の中で忘れてはいけない大事な問題がディメンチア、認知症の問題でございます。見ていただいたら分かりますように、先ほど言ったように高齢化が進む中でですね、ますますディメンチアの方、認知症の方が増えていくということで、見ていただくとお分かりいただけるということでございます。で現在はですね、今2012年の段階で、462万人の認知症の患者さんがいらっしゃる。またそのマイルドコグニティブインパワーメントという形であればですね、400万人ということで、1億2000万というイメージから見るとですね、ほぼ1000万人近くの方がですね、何らかの認知症が抱えながら日本で暮らしていく、こういった問題に対して我々は答えていかなきゃいけないということでございます。ただ一方で、高齢者が亡くなっていく場についてはですね、1950年代から見ると圧倒的に自宅で亡くなる方が減っていっている。また病院で亡くなるということが当たり前のような感じになってきている。そういった中で、どういう問題が起きますかといいますとですね、今医療費の高騰ということで、これは2009年の数字ではございますけれども、見ていただくと分かりますが、75歳以上の方と75歳以下の方で、医療費のですね、平均値を見るとですね、一番上の数字になって、4.7 倍、75歳以上の方が医療費を使わざるを得ないんですが、入院になりますと、それが 7.2 倍、外来ですと 3.8 倍ということで、入院の比率がですね、非常に多い、病床がたくさんある日本の現状ではですね、高齢化そのものが医療費の高騰に直結するという大きな、これまた課題になっているということでございます。 日本におけるですね、社会保障費の数値でございますけれども、確実に上昇しているわけでございます。国民の医療費、国民全体のですね、収入に対する比率というところをですね、赤い線が追っているわけでございますけれども、今現在ですね、もう 30% に至っているという状況になっているわけです。当然、65歳以上の方の社会保障費の利用の比率というものは当然上がっていくということで、これはもう厳然たる数字で今後もこのまま放置すればですね、全く同じように比例して上がっていくであろうという問題であります。ただそういった中でですね、日本は皆保険制度ということで、非常に堅固なシステムを1961年にほぼ完成をしてですね、1980年、80年、87年と、だんだん高齢者のですね、自己負担率はちょっとずつ上がってきてはいるものをですね、なんとか皆保険を維持しながらやってきている。ただそういった中で、保険料の未払いの問題、あるいは保険料が10% から 20% に上がる中で、さらに減っていく年金の中でさらにまた医療費も増えるということで、本当に高齢者の貧しい状態がますますこれによって助長されかねない、非常に生活に直結する問題として医療費の問題を捉えなきゃいけない、そういった状況になっています。でここまでは医療費のお話をさせていただきましたけれども、これは人口のですね、これからは少し密度、人がどういうふうに移動していくかということでございますけれども、見ていただくとですね、これはポピュレーションのコンセントレーションということで見ていただくと、実はなんとですね 66.4% の地域がこれからですね2050年にかけてまだ30年以上ありますけれども、人口が半減するというデータでございます。つまり、増えるところはほとんどありません。 1.9%。 人口は減りますし、さらにその減る割合がですね非常に地域格差がひどい、こういった状況に今後ますますなっていくわけです。でそうなるとですね、当たり前でございますけれども、徒歩でですね生活圏内で、例えば使える、ストアとかですねスーパーマーケットとかそういったところの、割合もどんどん減っていくということで、生活そのものがですね超高齢化の中で成り立たない、そういったような現象も起きかねないということです。ただその一方でですね、例えば東京、横浜のような地域ですとですね、逆に非常に高齢化がますます加速するというデータも出ております。東京、横浜はこれだけの人口を抱える3700万人、日本の中で人口を抱える非常に大きな地域になっています。ただその中で、医師の数はですね見ていただくと分かりますけれども、4万人近いと4万人ぐらいということでございますが、これは見ていただくと分かりますようにクリニックの数は非常に少ないということもございます。 33% ですから、コミュニティの中でこの、3000万4000万のですね高齢者を支えることが極めて困難である。つまり誰も家を訪れてくれない高齢者というのが、大都会の中では逆にどんどん増えていくというですね、また非常にアンビバレンスな状況が生じていくというふうに予想されています。また当然でございますけれども、日本では大家族というケースはほとんどなく、核家族化がますます進んでいく中で、独居で住む高齢者の割合というものも、数字として着実に増えているということでございます。また、貧困率に関してもですね見ていただくと分かりますが、80代70代から上の方の貧困率というのがですね、女性だと26%、28% ということで、実に4人に1人の高齢女性は非常に貧しい状態になっていく、こういった問題も今後出てくるということです。つまりまとめますと、スーパーエイジング、超高齢化の日本の中では、非常に大きな人口変動の中で、多疾病の疾患、そしてディメンチア、そして、医療費の非常に厳しい状況が続き、そういった状況の中でなおかつ、医療ケアというものがですね、軍部、僻地はもちろんですけれども、都会においても不足するという大変な状況が、出てくる。また高齢者の孤立、そして、貧困という問題も悪化していくわけであります。でそんな中で日本政府もですね、こういったエイジングポピュレーションの問題に対して、コストと、ヘルスイネクエティという先ほどの、医療の、不均一ですね、不公平の問題に関してですね考えなければいけませんし、なおかつ、医療費のことも考えなきゃいけないということで、なんとか入院の数を減らして、外来、そして在宅医療、ホームケ に対して、誘導するべくですね、さまざまな医療政策を、ここ10年、15年、打ち出してきたわけでございます。だんだんですね、実際に入院の数、なおかつ、専門医療の数というものはですね、徐々に制限されていく方向に現在向かっております。病院の機能そのものも超急性期、急性期、あるいは地域包括ケアという形でですね、機能を分けていくという動きも進んでいるわけです。で、そんな中でですね、GP、つまり、プライマリーケアを担う人たちの、パワーをもっともっと強化して支えなければいけない。これも、国も重々承知していることであります。また、地域包括ケアシステムという言葉で、国が打ち出しているシステムもございます。これはですね、この表は端的に表しておりますけれども、基本的には患者さん家族の自分自身を支えていく、自立していくところが基本にしながらですね、住まいの問題、生き方の問題を考え、また生活をサポートし、社会サービスでどうやってその生活を支えるかということをですね、社会全体で考えていく。で、その中でですね、メディカルケアという形で、医療の問題も出てきますし、同時に介護、リハビリ、そして、パブリックヘルス、公衆衛生、あるいは予防医学というものもですね、統合して展開していかなきゃいけない。で、これをですね、比較的小さなコミュニティ、我々の、国ではですね、中学校区レベルって表現をするんですけども、人口が大体3000人、5000人ぐらいのレベルで、これを一つ一つシステムとしてモデルにしていこうという形で動いているわけであります。つまり、日本全体の中でもですね、プライマリーケアを強化し、なるべく、アドバンストメディカルケアに行く方を、減らしていきたいということであります。ただ、一つ大きな問題があります。実際に、日本の中で、いわゆる、アドバンスメディカルケアという形で、各領域の専門家の先生が活躍されているわけでございますけれども、こういった先生がですね、特別なトレーニングはなく、なおかつ、さまざまなですね、その先生自身の努力に応じて開業をするという形で、地域でですね、プライマリーケアを担っているというのが、日本の現実でございます。で、もちろん現在、状況としてですね、決して日本の医療が崩壊しているということは全くないわけなんですけども、これからのこの社会の変革の中でこういう形で果たして日本のプライマリーケアが、永続できるのか、これが非常に大きな課題になっているわけであります。そういった中でファミリーメディスンというものをですね、19番目の専門領域として位置づけようということで、大きな専門医制度の改革というものが、現在行われつつあるという状況です。従来はですね、非常に今まで、専門医資格というものを特に取らないでですね、日本では医療することも当たり前だったんですけども、今後はですね、19個の基本領域、一番右側にジェネラルと書いてますが、総合診療という表現でですね、プライマリーケア領域、ファミリーメディスンの領域を担う医師をですね、専門家として育成しよう。こういった動きがようやくですね、国レベルで動き始めているわけです。そして現在、2014年、15年ということで、まさにこのレジデンシーのプログラムを現在構築している最中でございます。そして2017年からはですね、この実際のトレーニングがスタートし、2020年にはこの新しく、認定された専門医、家庭医療の専門医が誕生するという予定になっています。そういった中でですね、我々はトレーニングの中では少なくとも3年間、18ヶ月を総合診療、18ヶ月を内科小児科救急その他の領域をトレーニングするという研修プログラムを現在打ち出しているところです。3年間の中でこういった図のような形で続けていくという形になってきます。ただ現在ですね、そういった中で我々3つの問題を持っています。1つは指導医がいないということ。そして2つ目はですね、どうやってその量を増やせばいいのか。まだまだこの総合診療というものを目指す医学生あるいは研修医という方が多い状況ではございません。現在でも120名程度です。またどうやってこのクオリティを高めながらですね、他の医師からも評価される制度を作るか、大変大きな課題を抱えるという状況でございます。ただ私たち、超高齢化社会の先にはですね、持続していく日本というものを考えなければいけません。超高齢化社会の問題はイコール日本社会そのものの問題であります。未来の日本人のために、日本国民のためにですね、精一杯努力をしながらやっていく、これが我々プライマリーケアの人間の果たすべき責任、役割かというふうに考えているわけでございます。以上発表になりました。ご清聴ありがとうございました。
I would now like to ask our able speakers to come forward and take their seats, hopefully behind their own name tag, and like to invite the audience who's been listening with great interest to pose questions either to an individual or to the panel at large. Would you like to begin? And please introduce yourself and your nation of origin or your institution.
Ben Canny, Australia, Monash University. Thank you very much. I'd like to thank all the speakers for a very thought-provoking session. One of the questions I'd like to ask is, earlier today we were challenged by the idea that systems are designed to produce the outcomes they achieved, and that change requires something radical to occur. Perhaps King Hock could start in responding. One of the models of your system is that it's a move. It could be seen as a move of a gradual change away from a very hospital-based system to bringing the hospital into the community, and we're undergoing some degree of transition from a particular system into more community engagement. In my country, it's very similar to what happens in Amanda's country, that similarly generalists are trained in hospitals, then move into the community for later training. I suppose my challenge is, do we really believe that this gradual transition, continual recognition of the traditional medical hierarchy will achieve the changes that we need to bring about if we really are going to upset the apple cart and have a properly focused primary healthcare system that actually achieves the health outcomes for our community? Or are we just going to slowly drift to another position where primary care is seen as the second cousin or the younger sibling?
I will start by responding. So I think what I present is 9 years of very hard work, swimming upstream, fighting a lot of prejudice and preconceived ideas. It's very hard to change people's mindset of what is the packing order and where are the boxes you are. Now, even within primary care, I get resistance from people in primary care and family medicine because they feel uncomfortable. They say, why are you in the hospital? Why is a family doctor doing in a hospital? At least in my part of the world, it's very unusual. I think it's quite commonplace in North America. But I think we are now swimming with the current. I mean, the thanks in inverted comma to this aging population. The policy makers are very, very sharp. They are very objective, more objective than healthcare workers. Because healthcare workers, we are trained in a certain field, we have vested interests, we have our own little kingdoms that we want to protect. But the policymakers, on the other hand, are very, very sharp about where am I going to get the resources for the people. And now it's easy because our policymakers, our leaders are always telling us the present model is not sustainable. Almost a day, without a day goes by where they say that this present hospital-centric model is not sustainable. We need to shift care to the community, but I think they don't know how. And I think they look to the healthcare profession to give the answers, but I think we are very reluctant and slow to come forth with the answer. So I think the ball is truly in the court of healthcare professionals. And I think there are many people who are pushing the envelope, but I think it's a sort of irreversible trend. Short of the population suddenly transform to a younger population, it's a tide that you can't stop. But I think it will be tragic, it will be very painful with a lot of unnecessary pain and shortages of resources and unequal distribution of resources. If we as a healthcare professional do not quickly come up with the changes that are necessary and keep defending the old system. Yeah.
Rather than work one question through several different voices, let's give other opportunities to the floor to ask questions or make, yes, please, here, and then a second, there. Young man, rise. Introduce yourself, please. And
hi, I'm Masamitsu Takamatsu. I'm a medical student in Japan, and my question is to Professor Amanda Howe. So I spent last month in UK doing medical elective, and I was able to see some of the UK systems, and I was also able to spend a day in GP, and I was really amazed by the systems and the primary care that's being done. So I have two questions. So as Dr. Kusaba talked about, in Japan, we have a huge like a geographic disparity. Where I study down south in Kyushu, we have like a mountain area where there isn't so much hospitals or the clinics. So my first question is that in UK, I was told that there isn't much like a shortage of doctors in rural areas. If I was wondering if that's true. If so, then how do you guys have that system going on? And my second question is that, so I was talking to the medical students in UK, and I was surprised that like half of the students, go to the GP training as for the university I saw. So I was wondering, like, what are the factors that bring the young people to become GP in your country?
Thank you very much for both those questions. I think I'll answer the second one first. Although it's actually, there are not so many people applying for family medicine at the current time as in some previous eras. So we do see the popularity of specialties come and go, I think, in every country according to the political situation or the pressure of workload. But I have lived my whole life seeing this change, really. And the big change was when we had already a good established family medicine system in primary care, and I'm glad you enjoyed seeing that. But we didn't have students coming outside the hospital to train or residents doing much training in the community. And a big change happened when a combination of people like me saying, please let the students come out, because then they will learn good medicine, not just general practice family medicine, but actually good medicine in a community setting for some of the time, the reasons I said. And our leaders in the profession at that time agreed. They suddenly started to say, yeah, patients aren't in the hospital all the time. Why aren't we using primary care to help to teach and train? And so then students start to hear the voice of family medicine specialists and see what they do and learn about the patients and get that more chronic disease, epidemiological, patient-oriented idea. And it showed them the specialty they might like to do. So I think the first thing was exposure to the discipline in the training situation, as your resident showed us, and that made a big change. And then also the medical schools themselves putting people like me into the academic department. So again, you meet this colleague, you meet me, and people think, oh yeah, that's good, they're in the medical school. And once you're part of that, then it becomes a natural choice for the people who like that kind of medicine. Similarly with rural, actually I don't think it is such a happy picture as you experienced. And next week, I have to go home tonight or tomorrow morning because we have the World Organization Rural meeting in Europe, and the discourse there is it's much harder to get doctors to work in deprived populations, some of which are rural. But some of the secret is the same. Get the guys out there and train them to have a positive experience in rural, and then they begin to enjoy it and believe they could do it and meet the role models who have done it ahead of them. But it is also about government incentives and the money following where the needs of the patient are. So some of the other big ways of helping to get a good rural medical workforce or clinical workforce is to incentivize that and to build the infrastructure to meet the needs of those otherwise disadvantaged populations. So I think it's, action at lots of systems, but certainly people like you going out there and seeing it is a very beneficial thing. So thank you for the visit.
We had a second question here in front.
My name is from Medical School, University of São Paulo, Brazil.
Sao Paulo. There we go.
Thanks. My question is, it's about the career of a primary care physician. In Brazil, there's a very hard discussion about that. One side, the government pressured to introduce more clinical service of primary care in the network of a public service. But the problem is the payment of this kind of physician compared to specialists is so different. So primary care career is not attractive for the young doctors because the payment is not so considered well compared to the earned by the specialists. So in your country, how this kind of problem was solved just to payment of the primary care services, including public or the private sectors?
Let me tip that question over to Dr. Kusaba, because you were discussing financial reform.
じゃあ日本語でお答えしますけども、日本ではですね、実はプライマリーケアを今現在になっているドクター、開業医っていうふうに言われたりすることが多いんですが、そういった方の、報酬というのはですね、そうです、すみません、ちょっとyeah radio set
Number two
okay can listen to okay yeah 比較的ですね高いです。実はその病院、逆に言うとですね、病院の専門医の先生方の収入というのが他国に比べるとおそらく低いんだと思います。ですから相対的に言うとですね、給与の問題でプライマリーケアを選ばないという日本の若手医学生というものはほとんどいません。ですからどちらかというとスペシャリティとしてその確立していないので将来が不安であるというので選ばないというケースがほとんどですね。ですから逆にそのお金の問題は日本の場合にはその専門医とジェネラリストの格差というものはほとんどないと理解していただいていい。むしろある意味ジェネラリストの方がたくさんの収入を得ている方もいるというのが日本の現状です。
Let's have very short questions and answers because I just got petitioned to give time to my co-moderator here. But here.
Thank you. Mike Clagg from Johns Hopkins in Baltimore. So it's really it was a great session, and it was encouraging to see countries like Singapore and Japan planning for the future. Just a question for Dr. Lee Keng-hak. So the data you showed seemed to indicate that the length of stay in the hospital is over 5 days. I'm wondering, are there any initiatives in Singapore to reduce that length of stay? Because in the U.S., that would be a very long average length of stay. And that's another way to free up resources.
We are planning to cut down the length of stay. We are thinking of preventing unplanned readmissions, just like everyone else. Our length of stay is longer. I think it's sort of a tradition, but it's creeping down. And the government actually funds programs to say that if you have think of any innovative ways of reducing this length of stay, we're going to reward you. So we have various programs in all the different hospitals trying to do that. And one of the ways they think they can do that is to integrate services. They are integrating acute hospitals with community hospitals that I talk about, and then integrating them back into the community where there are services to support such a patient, so that the doctors in the acute hospital feel very confident that they can actually move the patients out straight back to the community and shorten the length of stay. A lot of the time is when they are stuck in a hospital is because of the lack of social services in the community to support the patient, or in the case of the doctors feeling uncomfortable or not confident that the primary care in the community can take care of the patient, which is why they tend to hold on to the patient longer than they should.
Good. You, sir, have the last question. Please proceed.
Yeah, Taroto Mizuka from Kyoto University. So, excuse me, in Japanese. で、質問なんですけども、医師としてクリニカルケアを教えるというのは結構問題ないと思うんですけども、先ほどホエイ、プロフェッサーホエイとドクター C は例えばインテグレーションのケアとか、あとコミュニティケアとかポピュレーションケアとかおっしゃっていたんですけど、そういったことをそういった視点を持つ医者をどうやって育てるかという点と、あと私はその政策の研究者なんですけれども、その政策としてそれは経済的な動機づけであったりそうじゃなかったりすると思うんですけども、どういった方法でそういったことをできるのか、理論的というよりは何か実証というか、今までこういったことが成功したという例があれば教えていただければと思います。
would you?
So I can try to address. So in terms of what policymakers can do to train clinicians in terms of
Thank you.
actually, there are many such initiatives.
Professor Shi, perhaps your microphone isn't fully on.
Oh, can you hear me? Okay. So many countries in Asia actually worked on this, and also in U.S. there are selected universities have improved their curriculum to train primary care specialty that emphasize continuum of care. I have directly worked with several agencies in China that have created new curriculum that adapted from both UK, Australia, and some other countries. And they try to work on, used to be the model is internship, looking at hospital as where you train all kinds of physicians. Now they emphasize externship, meaning community being the setting for training physicians, especially primary care physicians. So as you all know, for primary care physicians, diagnostic skills are critical because they are facing with patients who come in with new health problems. Unlike specialists who typically are referred, so they already have some first contact primary care physician telling them the situation. So primary care physicians have to be faced with different kinds of health situations, and only by having physicians working community, being faced with patients of different kinds of situations, can they learn those skills. So I think should start with changing medical curriculum, adding in externship, working in the community, rotation, different settings that deal with patients with different health problems.
Dr. Maruyama, you wanted to begin
to
close the session. Please proceed.
いいですか。最後はでも、一応乾先生もう一言だけ最後に言っていただいて、日本主催国の日本ですのでちょっとお話しますと、プライマリーケアの強化といいますが、それは実は現実的で実際的な課題ですね。それは特に頭の中で描いてできるものではありませんし、各国の実情があるわけです。そしてかつ日本の医療の質は診療所を含めますと、これは皆さんご承知のようにかなり高いと私は自負しているわけです。それが日本人がじゃあ今までどういうことにさらされてきたかといいますと、いくつかありますが、一つは非常に専門分化してきた医療に、第二次世界大戦後長期間さらされてます。でその中でエクスペクテーションも高くなっているし、ということなんですね。それから2つ目がユニバーサルカバレージで国民皆保障という皆保険の中にずっとさらされてきたと。でこれに慣れてます。でこれをずっとやってるのは日本は非常に珍しい国の方でありまして、保険証1枚で北海道の北から南の島までどこ行っても医療を受けられるわけです。今でもそうです。それからフリーアクセスと我々言ってますけども、これも保険証1枚でどこの医療機関でも病院でもどこでも断られることがありません、日本の医療は。それにならされていると。ですから我々がプライマリーケアの強化のためにある種の法略を立てようとすると、それは一般的には逆向きのベクトルであるというふうに捉えられることが多いわけです。多くのステークホルダーからですね。そこが非常に私は難しいところなんです。しかしながらアージェントイシューはたくさん出てきて、人口の問題もありますし、マルティモビリティ問題もいろんな問題があります。で今回のですね、最初に私が申しました19番目の領域の確立がどういうインパクトを持つかというと、おそらくですね、日本でプライマリーケアの強化を言うときに、これまではプライマリーケアで領域で働くことは、これインカムは別でございます。働くことそのもののリスペクトはあまりなかったと。そこがですね、19番目の領域に一つのアイデンティティとして確立することが、プライマリーケア領域で働く全般的な人々をリスペクトしてもらう形を作る一つのきっかけだと考えているわけです。そこで私ども必死でそれをやってきたという思いがありまして、実はこの総合診療専門医が19番目に確立してドラスティックに何が変わるかということよりも、領域が一つ確立されたということがですね、僕らにとっては非常に大事なことだということを最後に付け加えさせていただきたいと。その中で今後ですね、今日のセッションで皆さん方の ご意見をお聞きしまして、やっぱりいいとこ取りを我々はしていく必要があると。つまり成熟した医療の中でのプライマリーケアの強化というのは、これまた違う意味のですね、チャレンジングなことなんであるということを最後に申しておきたいと思います。
I'm tearing up my notes. I had many. I wanted to say just this, that about 150 years ago, the pathologist Rudolf Virchow said that all medicine is politics, and politics is medicine writ large. I think that if you add up the elements of observation that have come forward in this very interesting panel, thank you so much, that you might come to the conclusion that what's at stake is civil society, the equity that and fairness with which we hope to treat and respect the elderly who have given so much, but now whose welfare may be dependent upon 1.4 workers. The long-suffering daughters-in-law, whom we have not heard much about, who in this society put the care responsibilities on their shoulders as they attempt to take care of their parents, especially their mothers, who might end up in poverty and living alone. I think that the Japanese society treasures civil society and will find a way politically to invest in that which is necessary, whether it's information systems or new health workforce training or new models of organization of care, to do what is necessary to do for the elderly as a test almost of the moral core of the Japanese people. So thank you so much for coming to this discussion, and thank you for the presentations you made.
Thank you very much.
丸山先生、乾先生、ご登壇いただきました皆様、ありがとうございました。これにてパネルディスカッションを終了いたします。